Good morning, everyone. We are Group 3. Today we are going to present case conference in orthopedic, and we have 5 members. First, Walankana Jalilmatana, number 007. Second, Shanatit Pomsang, number 010. Third, Ponchanok Pisesit, number 018. Fourth, Antisan Sinchalasit, number 034. Fifth, Apasala Subanchati, number 036. The patient is a 75 years old Thai female who is unable to ambulate independently due to pain and restricted movement of the left lower extremity for 3 days post-operatively. This is her body chart. Her head is 160 cm and her weight is 56 kg. Subjective examination. Subjective examination. February 8, 2026. The patient tripped and fell in front of her house, landing on her left hip, so she was unable to stand up due to the severe pain. Numeric rating scale is 10/10. Unable assisted her back into the house. While at home, a traditional massage therapist was invited to provide massage therapy. On February 10, 2026, since the day of injury, the patient had received massage therapy for 3 times. However, the pain progressively worsened. Numeric rating scale is 10/10. So her doctor brought her to Stone Hospital, and X-ray revealed a left interchangeal fracture. Patient initially refused surgery treatment, so she referred to Sungkanakalin Hospital for alternative management. February 11, 2026, the patient was transferred to Sungkanakalin Hospital, and her pain level remains severe. Numeric rating scale is 10/10. The left lower extreme showed no swelling, but there was a bruising in the left bone area, and active movement of the left leg was limited due to pain. The physician recommended surgery intervention, so the patient admitted and scheduled for surgery in 2 days, and she got instead to pain management, reducing pain to numeric rating scale 8/10, and she got respiratory training by using a dry flow for reduced post-operative complications. February 13, 2026, the patient underwent cost reduction and internal fixation with short proximal femoral nail anti-rotation for a left interchangeal fracture. Post-operatively, a Foley catheter was inserted. The patient reported left leg pain. Numeric rating scale is 5/10. Swelling of the left lower extremity was observed and limit range of motion due to pain. She got cold compression by nursing staff and morphine for pain control. The pain decreased to numeric rating scale 3/10. The patient was referred to physical therapy department for weight training using a walker with weight bearing as tolerated on the left lower extremity. February 15, 2026, the patient was available in the morning. She reported increased pain. Numeric rating scale 8/10 and was administered aspirin for pain relief. The pain decreased to numeric rating scale 5/10. The surgery wound was clean and dried with no discharge. The patient was able to ambulate using a walker. No swelling was observed in the left lower extremity. However, there was tightness around the surgery site. February 16, 2026, on initial evaluation by physical therapy student, the Foley catheter had already been removed. The patient reported pain at numeric rating scale is 5/10. Swelling and tightness was observed around the surgery site of the left leg. The patient was able to ambulate 150 meters using walker. Aggravating factor, pain at the surgical site when turning side lying position. Easing factor is letting a supine position, and 24-hour behavior of symptoms at AM. Due aging pain in the operated leg, numeric rating scale is 5/10. At PM, persistent aging pain in the operated leg, numeric rating scale is 5/10. And at night, severe pain in the operated leg causing inability to sleep, numeric rating scale is 10/10. So she have to inject able analgesic to require for pain relief. Next is hypothesis, impairment, and functional limitation. Hypothesis called left interchangeal fracture stated post-close reduction and internal fixation with short proximal femoral nail anti-rotation. In ulcer, we might see left leg muscle mass less than right leg. In skin color, we might see ecchymosis. On the X-ray, we will see core fracture left interchangeally, and the palpation, we might see swelling with heat at left knee, and pitting edema is grade 2 plus. Active movement test, we might see limit active range of motion by pain of left leg or direction. Numeric rating scale at 5/10. And passive movement test, limit passive range of motion by pain of left leg or direction. Numeric rating scale is 7/10. Functional ability, bed mobility independent with compensation. Gross motor contact guarding. Manual muscle test, left leg muscle weakness. Sensation is loosened. Balance might vary. ADL intermediate initial score. Ambulation walking with walker. Special test, leg length discrepancy. Asymmetrical leg length size and asymmetrical leg circumference.
General appearance. The patient had good conscience and showed good operation during examination. The surgical wound is covered with a gauze over the hip regions. Some superficial dry wounds are observed with or called before the surgery. In addition, ecchymosis is present around the hip area, indicating post-operative soft tissue injury. The next circumference assessment indicates swelling with sustained inflammation after hip surgery. Postural observation in standing show thoracic kyphosis, which may be related to muscle imbalance and age-related structural change. During palpation, swelling and warmth are noted with a sign of inflammation following surgery. ARM and PRM, the patient present with limit, active and passive range of motion of hip all direction due to pain. This limitation caused by post-operative inflammation and soft tissue injury around the surgical area. Muscle guarding and pain may lead to the patient avoid the movement, resulting in decreased hip mobility.
And next, I perform manual muscle testing, focusing mainly on the lower extremities in the patient underwent left hip surgery. The muscle weakness was primarily observed on the left with the surgical side. For the left hip muscle, the hip flexor were grade 4 out of 5, the hip extensor, abductor, and adductors were grade 4 plus out of 5. At the left knee, both the knee flexor and extensor were grade 4 out of 5, as the ankle muscle strength was 5 out of 5 bilaterally, indicating normal muscle strength at the ankle level. So that means patient has mild weakness of left hip muscle and knee muscle. The patient underwent surgery on the left hip, resulting in post-operative pain and soft tissue injury around the joint. Consequently, muscle strength in the hip and knee on the operative side has decreased compared to the unaffected side. And next is functional ability. Let's see bed mobility. Patient can do move upward and move downward independent, but with incorrect movement, and can do move sideways to unaffected side, that means right side, and move sideways to affected side, that means left side. Patient can do independent. The patient does not flex the left knee, but instead pull on the bedside rail while moving upward and downward. This is presumed to be down to a lack of knowledge regarding proper movement technique. Although the patient is able to flex the left knee post-operatively, pain is present with mainly the patient to rely on pulling the bedside rail rather than bending the knee, resulting in incorrect movement. And next is gross motor function. First is supine to side lying to unaffected side, and side lying to sitting. Patient can do independent, and sitting to standing and standing to sitting. Patient can independent with walker. The patient recently underwent left hip surgery and therefore use an assistive device to enhance stability during sitting, standing, and ambulation, as well as to prevent fall. And next is balance. The patient is able to bear it on the left side, which is the operated hip, allowing the patient to maintain balance in both sitting and standing position during both static and dynamic activity. And next is spatial test. I assess for long leg discrepancy. The left leg measures 84 cm, while the right leg measures 86 cm. Therefore, there is a 2 cm long leg discrepancy, with the right leg being longer than the left. It is caused by a hip fracture, which results in displacement of the normal bony alignment. In addition, surgical treatment with close reduction and internal fixation using a sharp proximal femoral nail anti-rotation may alter the position and tension of the subriding muscle and tendon, leading to post-operative leg length discrepancy.
Next, we will talk about the problem list and analysis. We will talk about the problem list in this case. It's an inability to walk independently, requiring of use a walker. And next, we will talk about the functional limitation. In this case, it's inability to bearing weight on the left lower limb due to pain. Next, we will talk about their impairment. In this case, we found the poor postures, swelling with warm at left hip, and also have a limit active and passive range of motion of left hip in all direction due to pain, and have a mild weakness of hip and knee muscles. And the last one, we found the leg range discrepancy of 2 cm right more than left. Next, we will talk about the pathology in this case. This patient is sustained a fall with direct impact to the left hip. The mechanical force will transmit through the greater trochanter to the intertrochanteric region of the femur, resulting in the cross flexor. Following that, the flexor, small blood vessel around the bone will disrupt, and leading to hematoma formation. Next, the patient later underwent close reduction and internal fixation or CRIF with the proximal femoral nail anti-rotation or PFNA to stabilize the fracture, the ortho fixation, restore bone alignment and mechanical stability. Surgical trauma further stimulate inflammation. And pain and inflammation inhibit muscle activation, resulting in weakness of hip and knee muscle, as well as also limit range of motion of the left hip, make the patient inability to work independently, requiring the use of the walker for ambulation after surgery. Next, we will talk about the physical therapy diagnosis of this case. This PT diagnosis is the patient is unable to ambulate independently due to pain and limited range of motion of the left lower extremity following surgery for the past 3 days.
And next, I will talk about goal. Long-term goal, the patient will be able to walk independently with a normal gait pattern within 4 months. Short-term goal, the patient will be able to perform bed mobility with proper movement pattern after the first visit of physical therapy student. Reduce the pain from pain score 5/10 to 2/10 and swelling within 1 week. The patient will be able to fully weight bearing on opposite leg while using a walker within 2 weeks. Increase volume of hip in all directions except left hip internal rotate, hip adduction and hip flexion within 2 weeks.
Improve left hip flexor strength from grade 4 to grade 5 within 5 weeks. Improve left hip extensor strength from grade 4 pass to grade 5 within 4 weeks. Improve left hip adductor strength from grade 4 pass to grade 5 within 4 weeks. Improve left hip abductor strength from grade 4 pass to grade 5 within 4 weeks. Improve left knee flexor strength from grade 4 to grade 5 within 5 weeks. Improve left knee extensor strength from grade 4 to grade 5 within 5 weeks. And the patient will be able to walk independently using a cane when going outside within 2 months. Precaution and contraindication. Monitor for pain in the left thigh during the therapeutic intervention. Avoid position that increase risk of hip dislocation, including hip internal rotation, hip adduction, and hip flexion. Be cautious to prevent IV line displacement during physical therapy. Monitor for signs of orthostatic hypotension. Regularly assess vital signs and observe for symptoms such as dizziness, lightheadedness, and fatigue. Take precaution to prevent recurring falls. Let's go to the treatment plan. First, reduce pain and swelling in the thigh using the RICE principle: rest, ice, compression, and elevation. Second, strengthen the following muscle, including left hip flexor, left hip extensor, left hip adductor, left knee flexor, and knee extensor, and strength about bicep brachii, and gluteal muscle. Third, balance training. Fourth, gait training. Fifth, patient education. The treatment details. First, RICE principles consisting of 4 components: rest, ice, compression, and elevation. Rest, avoiding weight bearing activity or movement in both the affected leg. Can use assistive device such as cane or walker, may be used to allow proper recovery of the injury muscle and joint. Ice, use cold application such as ice pack to injury area to reduce inflammation. Apply for 15 minutes per session every 2 to 3 hours, continuously during the first 48 hours after injury. Compression, use an elastic band to wrap the injury area. Avoid wrapping to tightly. Monitor distal circulation such as the skin should not become power, wrist, or numb. And finally, elevation. Elevate the injury limb above level heart or place a pillow under the knee and leg to reduce swelling. Left hip flexor method. Sit at the bedside, lift the leg toward the chest at your rate. Then slowly lower it back to starting position. Frequency 10 to 15 repetitions per set, 2 to 3 sets per day, and 3 to 5 days per week. Left hip extensor method. Stand while holding a walker or table for support. Extend the leg backward as far as possible without losing balance. Frequency 10 to 15 repetitions per set, 2 to 3 sets per day, 3 to 5 days per week. Hip adductor method. Lie supine with knee bent. Place a small pillow between the knee. Squeeze and hold for 5 seconds, then relax. Frequency 10 to 15 repetitions per set, 2 to 3 sets per day, 3 to 5 days per week. Left hip abductor method. Stand while holding a walker or table. Move the leg outward as far as possible without losing balance. Frequency 10 to 15 repetitions per set, 2 to 3 sets per day, 3 to 5 days per week. Left knee flexor method. Stand while holding a walker for support. Bend the left knee backward as far as possible while keeping the thigh in the neutral position. Slowly return the leg to starting position. 10 repetitions, 2 to 3 sets per day, 3 to 5 days per week. Left knee extensor. Sit at the edge of bed. Slowly strengthen the left knee until the leg is full extend. Then slowly lower the leg back to the starting position and relax. 10 repetitions, 3 sets per day. Bicep brachii method. Sit while holding 600 ml water bottle. Keep the arm close to the body. Flex the elbow fully. Hold for 3 seconds, then slowly lower. Frequency 10 repetitions per set, 2 to 3 sets per day, 3 to 5 days per week. Tricep brachii. Sit while holding 600 ml water bottle. Light the arm. Bend the elbow backward, then extend elbow until strength. Frequency 5 to 10 repetitions per set, 2 to 3 sets per day, 3 to 5 days per week. Gluteal muscle method. Lie supine, contact the gluteal muscle and hold for 5 to 10 seconds, then relax. Frequency 5 to 10 repetitions per set, 3 sets per day, 5 days per week. Balance training method. Stand while holding a walker. Keep feet shoulder width apart. Gradually shift body weight from left to right, then forward and backward without lifting the feet. Frequency 10 repetitions per direction, 2 to 3 sets per day, 3 to 5 days per week. Gait training. The patient stand while holding the walker firmly with both hands. To initiate walking, move the walker forward approximately 1 step length. Step the opposite leg forward into the walker frame first.
followed by the unaffected leg. Maintain upright posture, look forward, and weight bearing should be performed as tolerate. And finally, education. First, advise the patient to maintain a safe home environment. Floor should be non-slippery. Second, advise the patient to avoid walking in poorly lit area, especially at night. Ensure adequate lighting. Third, advise the patient to avoid lifting heavy objects in the early rehabilitation phase. Fourth, advise the patient to be cautious with bed mobility. Avoid dragging the body across the bed to reduce friction and shear force, which may increase risk of pressure ulcer. Proper breathing technique or correct turning method should be instead.